if data isn't collected accurately, it does lead to a poor plan of care. It can lead to inaccurate patient care health profiles. It can be a flawed data set upon which your organization or Medicare may base decisions. And so whatever data they have, they base decisions on it. It may not be the right decision. And there is a potential for less than good outcomes for patients. An example of this is that, say I collect data at the beginning, but I don't accurately represent the functional abilities of the patient, and I really make them too functionally independent. And I score them as a 1 in the start of care. And in reality, they are a 3 at the start of care. And at the end, when we do the discharge Oasis, they're still a 1. Or they are a 1 now because we've done our work, we've done our therapy, we've progressed them from one point to another point, and so they really are a 1. However, what the data sees is the start of care was inaccurately collected as a 1, and at the end it is a 1, when in reality it was a 3 and now it's a 1. So again, very important that the outcomes are stated accurately for what we do. So what has been said by your staff about Oasis is I was part of the pilot Oasis project in the United States. I really heard a lot from my staff about it. Most of it was very negative. I didn't really hear anything positive, to be quite honest with you, at that point in time. So it was too long. It was too burdensome. My visit times have increased. My productivity has gone down. And of course, the big one was it's 23 pages long. What do you expect us to do? Most organizations had maybe a 10-page assessment, and all of a sudden this Oasis was placed in the mix, and it was 23 pages long, and we also added other assessment tools to make it a comprehensive assessment. So there might have been a nutritional assessment, a falls risk assessment. So it became a 30 to 40-page document. And I would tell you that I do believe that Oasis is a good tool, but I also would tell you that any director in the early stages of Oasis commiserated with staff and told them, really sorry, this has to be done. We understand it is, instead of putting it in a positive light about how the tool was going to collect data, we actually put it in a negative light of, poor staff members having to do this. So in some ways, it became get through the paperwork as fast as you can. I can speak to this because I was out there doing Oasises. So, and it's not to be taken like that. And I am really sorry that I did that when I look back. So now what I put forth to people that I teach is the assessment strategy should be, I call them IOMs or IOMs, and they are interaction, observation, and measurement. As much as possible, this should be the way of the assessment, and I would tell you that IOMs have been timed, and in actuality, the Oasis assessment with an IOM being done in a specific, not in a specific way, but a specific technique that your staff might use, it tasks out to be 6 to 8 minutes shorter than if you did an Oasis assessment as it would normally be done by staff, mostly by interviewing process with some measurements taken, and the data collection is much more accurate. So we could start here with interaction. We're sitting down, we're talking with the patient when we meet with them, we're getting some information from them, but we are having a dialogue with patients. The interaction technique is avoid directly asked questions requiring a yes or no answer. Very important. You should use open-ended questions and leading questions. Tell me when this happened. Describe for me your pain. How often does it happen? Not do you have pain? So those are the types of questions on interaction with the patient you should have. Use the words the patient can relate to. I actually did a study one time on 50 patients, and I asked them, did they know what the word incontinence meant? And, you know, so many said yes and so many said no. But of the ones who said yes, I started to ask them questions about incontinence. And in reality, they did not know what the word incontinence meant because they answered the question incorrectly. So we have to use words the patient can relate to. Not are you dyspneic, but do you have shortness of breath? When does the shortness of breath occur? How far can you walk before you become short of breath? Those types of things. So we have to tend to stay away from the medical words and use words that the people can relate to when we're doing these assessments. Observation. We can learn a tremendous amount with our clinical competencies and our observations. And we don't even need to ask or have interventions with people. We should just watch them and listen. You know, use our own senses. Touch, smell, sight, hearing. Use our own senses to observe. And of course, we do have to do measurements. They are very important, but they also give us concrete, measurable data, number data. So the 6 simple steps that I talk about with this is you call the patient and you schedule the visit with a window of time. The second part would be you greet the patient at the door. You review the home care, your agency, the insurance of the patient, and you talk about the program and have the person sign a consent. Then you ask the patient to show you their meds. You ask the patient to show them their bathroom and ask the patient to show you their bedroom. So these 6 steps are really all it is with the observational portion of it, with really the whole piece, the IAMS itself.